Okay, Russell Barkley is a medical doctor, psychiatrist in, I think it was Harvard, and he's sort of the guru in this area. ADHD is not a problem with knowing what to do, it's a problem with doing what you know. So even in the interventions, like they will do great in the situation where you're teaching them, but then they go out, you know, maybe even in the hallway or in the car on their way home, and they know they're not supposed to do this, and they did it, right? Because it works well in the situation, and hopefully over time, repeat and practice, that the children will generalize that to other environments. But it's usually going to be more effective if the redirection is going to be happening right there and then. So in other words, in the classroom, at home, at the grocery store is where the behaviors need to be redirected and not wait until they get home or something like that, right? All right, behavioral disinhibition is the basis of executive functioning deficits in ADHD, a performance rather than a knowledge deficit. So in sum, ADHD is a developmental disorder that affects their ability or their performance to do things. Okay? Inattention and executive functioning, we've gone through all of these. Let's see, 30% rule talks about subtract 30% of their age. So in other words, if their chronological age is 10, they're probably functioning at age 7. So these children usually are more, they come across as more immature, they're delayed emotionally. So even though they're cognitively, or not cognitively, but chronologically at this age, they're always functioning about 30% lower than their actual age, okay? This helps us understand why their behavior is what it is. And so even in treatment or in the classroom, you're probably wanting to teach them at that age level, that emotional level that they're functioning at. And hopefully we're going to try to even out the playing field so that as they mature, the gap is not as much. Okay. What would the executive functioning deficit look like? Again, difficulties with self-regulation, limiting self-awareness or self-monitoring, poor use of hindsight, impaired sense, difficulty following rules, poor emotional control, and so forth. What causes it? Well, we know, again, that it's a neurological genetic disorder. It's a single dimension that varies in severity. So not every ADHD child is going to look the same. You know, some of them may have more hyperactivity and less inattentive, or some are more inattentive and less hyperactive, or maybe some are both. All currently recognized causes fall in the realm of biology and neurology and genetics. Maternal smoking and alcohol in pregnancy is known to cause ADHD. Premature births, especially brain bleeding, and then maternal diabetes during pregnancy can also cause this. So there's a lot of correlation with the neonatal problems. Most cases are inherited. Siblings, there's 25 to 35% correlation. Mothers, 15 to 20. So if mom has it, there's up to a 20% chance that child will have it. Look in twins. There's almost like, you know, up to 92% of the time if a twin has it, the other one will too. And then fathers are higher. So if you want to blame somebody, say, Dad, it's your fault. 20 to 30% of the time, Dad is the one who's going to. All right, genetic contribution. Overall, 80% of the time when they have ADHD, it was genetically induced or passed on. Okay, it wasn't caused by the environment or lack of parenting, or, you know, although those factors do contribute, that's not the reason. So that really, if you put this in perspective for the parents, it helps them feel better, like you are a good parent. It's just, you know, maybe, you know, down the line, it just got passed down. So no contribution of the rearing environment, the most genetic disorder known to science, and the only others are depression and autism. Also bipolar disorder is very genetic. Okay, what doesn't cause it? What does not cause it? Food allergies doesn't cause it. Sugar doesn't cause it, and milk and their diets don't cause it. Although this does help, because there's been a lot of research having to do with the gut-brain sort of connection. Excessive caffeine in your diet doesn't cause it. Environmental allergies. Oh, it's because of his allergies he got ADHD? No. Poor child management by parents doesn't cause it. Neither does family stress. Excessive TV, too much video games does not cause it, and neither does increased cultural tempo. Okay?
Now that we've talked a little bit about kind of the diagnostic portion and what are the features of ADHD, we're going to move more toward treatment. Okay, so when we're treating ADHD, we're really treating a global problem because we're seeing this behavior in multiple settings. So breaking down the stages of treatment, we're looking at evaluating the child. So identifying what are the exact symptoms that this child's dealing with. Are they more inattentive? Are they more hyperactive? And then educating parents on what is ADHD. That ADD is actually called ADHD. That's probably one of the things that stands out to me. And I'll break these down a little bit further as we go along. We're going to do a broad overview of medication. We'll talk about behavior modification. So how do you modify your child's behavior and how can you control that? As well as parent-child interactions and any environmental accommodations. So we'll talk about what goes on in the classroom and how can we address the specific problems that this student is having within a classroom setting. Okay? So there are a lot of evidence-based treatments for ADHD. Dr. Livingston touched on the notion that therapy in conjunction with medication works for most people. That's the best combination. That gives you the greatest outcomes, meaning that symptoms are reduced and academic performance is increased. So the first and one of the most major pieces of treatment is the parental education part. So really educating on the ins and outs of ADHD, the etiology, some of the things that we touched on in terms of the frontal lobe and how it's a brain disorder. There's a lot of biology behind it. And like Dr. Livingston kind of touched on, it's not based on diets and things of that sort. So really kind of just giving parents information about it and also validating a parent's experience of how difficult it is to have a child that has ADHD and that it is really stressful. And nothing you did caused this, so kind of just being that sounding board and allowing a parent to know that they're not alone, that this is a very common disorder in children, and that there's help out there and things that work, okay? I think a lot of times parents need to hear that kind of reinforcement. We're always so focused on the child, but also this is a big, big treatment proportion is how is your treatment in therapy, that 1 hour a week, how is that translating at home? So parents are very heavily involved in this, hopefully. Okay. So let's talk briefly about medications. Obviously, I'm not a physician, but I've taken quite a few pharmacology classes in my graduate training, so I'll just give you kind of a brief overview. And then we'll talk about in a little bit why we give stimulants to hyperactive kids. Okay. So the number one, or the kind of go-to treatment for most physicians are stimulant medications. So these are things like Ritalin, Adderall, Vyvanse, Concerta. Those are probably the big ones that you've heard of. They're amphetamines. So why do we give this medication? We will talk about it in a minute. We're trying to calm those stimulating behaviors that we touched on a little bit earlier, the tapping. This is a stimulating behavior. So now I'm going to try to do something else by giving medication to decrease this behavior, and now I'm being internally stimulated. Okay, so we'll talk about that in a little bit. There's also medication, Strattera. That's an SNRI. You can use it to treat anxiety and depression as well. But it also impacts your frontal lobe and your functioning. So it's very commonly prescribed to children who have problems tolerating stimulants. So if they're losing a lot of weight, they're not sleeping well, physicians will be open to trying an SNRI. And then also the antihypertensives, so Intuniv is sometimes prescribed as well. I know that some kids that are on Intuitive, they take it at night, so it just works, the mechanisms work a little bit differently than your go-to stimulants or the SNRIs. We'll talk about parent management in a minute as well, where we can do different strategies, such as implement a token economy in the home to help manage your child's behavior. So at the end of the day, we have X amount of attention that we can give somebody. If we're only giving negative attention to the negative behaviors, that's all our child is going to do, okay? We all want attention. We're all human, right? And your kids are going to want your attention, or your students are going to want your attention. If they can only get it in a negative way, I did this great thing, that's wonderful. I did this horrible thing, now I'm getting a 15-minute lecture on why I'm getting 15 minutes of unadulterated time. So learning how to use your attention as a reinforcer. We're going to talk about some teacher education, classroom implementation. What are some of the classroom accommodations or something you've seen, maybe if it's been your patient that you've recommended to a teacher or something in terms of an academic accommodation to help a child that has ADHD to help them with school? Can anyone think of something?
Sitting next to students that are not hyper and talkative and distraction.
Awesome. Preferential seating, that's one of the main academic accommodations that kids might get. Can anyone think of anything else? Or even if you don't have experience, maybe shooting out some ideas of what you might, from what you learned today, think would be helpful. Go ahead.
Some of our kids wear quiet
Noise canceling headphones? Awesome. That's great if you have that resource. That's wonderful.
Study Carol?
Pardon?
Study Carol?
Can you speak more on that?
Study Carol, like what is it? It's just a desk with 3 walls.
Oh, okay.
So
there's not any
yeah, you have to turn around to see something else.
There you go. Preparing for the cubicle life. Yeah, that could be very helpful. Anything else?
So, like repeating directions back, or maybe having all their colleagues in different areas so that they're not at their.
Excellent. Excellent. What if we walk into class and I say, okay, everybody, sit down, take out your English books, open to page 74 and do questions 1 through 5. Yeah, that's way too much. You lost me at sit down. So if you're giving complex verbal commands and we're not breaking things down one at a time, that child's going to be very lost. Okay, so kind of simplifying your instructions or writing them down. 1, 2, 3, 4. Okay. Now, this being Texas, I think my graduating class was 1,018. We have very large classrooms. So obviously when a teacher is trying to manage 30 students, it can get very demanding on the teacher to, pay a lot of their attention to this one child, and then they have 29 other kids that they're trying. So it's very difficult for teachers, and I do not envy them having to do that. So hopefully teachers are willing to be flexible and accommodate and work with parents, work with the school psychologists, work with anyone that's involved in the treatment of the child in order to better facilitate academic success. And with academic success, we know that social skills come with that as well. So if we can make school a little bit more of a pleasant place, hopefully it's not as boring, which is one of the factors that was risky for a child that has ADHD, and we want to succeed and we want to listen, okay? So working really closely, I used to monitor Head Start classrooms when I lived in West Virginia, and that was something that we worked a lot with the Head Start teachers and teachers' aides on. Here are the kids that, looking in your classroom, that have the most problematic behaviors. Let's try to do lessons that can involve all of the children, and if we give them certain tasks or we give them positive reinforcement or they have responsibilities that are developmentally appropriate for that 30% age gap that we talked about, how can we ensure that they're doing well and also incorporating that into the classroom, okay? Some of the other things Dr. Livingston kind of touched on, when someone that has ADHD gets a list of things to do, that can be very overwhelming, Okay, so I have 15 different worksheets for homework. I'm impulsive, I'm just gonna crumble them, shove them in the back of my backpack, and then I'm not gonna do them. Or a lot of times what we'll see is, parents will sit down, they'll do the homework for hours, it's very painful. And then the kid will go to school and they'll have their homework, but they don't turn it in, right? Because I can't organize, I'm forgetful, I'm not paying attention, that's not that important, it's kind of boring. So finding some sort of method that works well for parent and teacher, whether that's communicating through the use of a folder or trying to find something that works well. Okay. Again, we look at the environment in the classroom. Like you said, when we have the 3 walls, classrooms are very colorful, very stimulating. So if there's a lot to look out, if there's windows, they're going to be likely looking out. So moving them away from the windows, up toward the teacher, those are all things that we can do in a classroom to help, okay? Having some sort of liaison, again, so whether that's your school psychologist or your counselor or your parents, someone that's talking between teacher and parent. We're all getting on the same page here because these are problems that are global, again, so they're occurring at home, they're occurring at school, and we're wanting to, the best treatment is if we're treating all of them at the same time. Again, decreasing workload, not retaining these kids in grades just because they're inattentive or hyperactive, okay? Because they likely have the ability to do the work and the knowledge and the skills that is needed. They're just kind of working through the kinks, okay? So if they don't have, another reason to be retained, such as a learning disability or, poor academic performance, not making them fail a year or skip, or stay behind and lose out on any friendships that they may have made just because of their inattention or their hyperactivity. Smaller classes, well, that's an option. Preferential seating, so we've kind of talked about all of these. If I can't focus on things, if you think about having an in-basket, and if you go on vacation for, a week, if you're so lucky, and you come back to all of these tasks that you have to complete, and you have to prioritize, and you have deadlines, and you're juggling a million things at once, that's very difficult for a typically developing adult, right? So adding an attention deficit problem on top of that really can inhibit your progression in work. So they have greater likelihoods of unemployment, more sick days, more likely to be dismissed or fired. If I'm maybe not hyperactive anymore, but I'm impulsive, and if my boss says something that I don't like, and I might shoot back and say something that I didn't mean to say, but I didn't have that inhibitory control. And then again, more vehicle accidents, more arrests. There's a huge correlation between inmates who have had prior diagnoses of ADHD. Okay. So I wanted to talk about the theory of optimal arousal. So again, why would we give a hyperactive kid who's climbing on the walls a stimulant, right? We drink coffee, we take our stimulant every morning to get us going. So why would we ever want a child to have more go, okay?